Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. So welcome, everybody. So you probably know this old and, sort of corny joke, right? Three men walk into a bar and then there's some sort of a conversation and, something happens in a joke that makes you laugh. So I thought I would repurpose Three Men Walk Into because a patient recently shared with me a conversation that he had with two other guys on a golf course. So no offense to women, it's just basically I'm capturing the real story. And so this is how it went, right? The three guys went onto a golf course and one guy said, "Oh, I had a coronary artery calcium score recently and my score was 3,000. And another guy says, "I also had a coronary artery calcium score recently, and my score is 75. And another guy says, "Well, I also had a coronary artery calcium score recently, and my score is 220. So my patient was wondering, what is he to make of all of these calcium scores? Because he was actually coming in for a comprehensive evaluation. And as part of this evaluation, we do a very extensive vascular scanning. We look at the carotid arteries and the ultrasound of the heart and the abdominal aorta. And of course, depending on the level of risk, I very often send my patients for a calcium score. And sometimes it's a calcium score combined with coronary CT angiography, something that we will discuss later on. But what I'm finding working with a lot of patients is that numbers are sort of meaningless to a lot of individuals. When they do get the calcium score, they don't quite understand what it means. Now, you probably intuitively understand that a calcium score of 3,000 isn't really good. And this is something that most people would agree, right? 3,000 is really, really high, especially if we consider that the best case scenario for any person is to have a calcium score of 0. And we'll talk about calcium score of 0 and what does it mean in terms of the chances of having a soft plaque in a separate discussion. But for now, let's stick with our three men who walk onto the golf course, and each of them just happen to have a certain calcium score. And I'd like to show you how to actually use this information, these numbers that you are collecting from your calcium scans or from blood work, and put it in context. And this context is very specific because today's episode in the Calcium Score Revisited is actually about vascular age, right? And a lot of patients don't really understand or don't get an explanation perhaps from their physicians who are ordering calcium scans that the numbers are more than just an indicator of the level of atherosclerosis or damage in the coronary arteries. They also tell us something else. They tell us about the rate of progression of these changes in the coronary arteries and the arteries in general. And that essentially is an estimate of a vascular age. Now, vascular age is an interesting concept because we can estimate it, and I'll walk you through all the steps in the process. And if you're listening to this on the audio platform of your choice, I think this is one of those episodes where YouTube is best because you do want to see the things that I'm going to show you, the steps sort of in action so that you can understand it for yourself. And if you have the data, you can go to the resources. They're publicly available to you. I'll put the links in the show notes so that you can navigate to the same resource. And if you have the numbers, you'll plug in your numbers and actually you will know what those numbers mean. And I would love to see more physicians putting it in their patient assessments and in their notes. To date, I had seen it in some of the notes, but that's usually in the minority. So that's why I feel that for you to own your heart health, you have to advocate for yourself and use some of the tools that were initially meant to be practitioner focused, but use it for yourself. And I want to walk you through this process.
Hi everyone, it's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity, and discussion often gets heated and confusing. There are those who push for low fat, low cholesterol, and then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours.
So 3 men, they walk onto the golf course and one says, my coronary artery calcium score is 3,000. So 3,000 or even 1,000 is high. And you could certainly expect what I'm going to share next is that this gentleman ended up going into the invasive coronary angiography and ended up with a couple of stents. And if you are someone who is considering a stent or underwent a stent procedure, we can certainly talk later on, what the stents are and why some people need to get them and some people don't need to get them. There is a very interesting and rapidly progressing body of knowledge in that area that a few years back sort of shifted the paradigm on who gets stented and who doesn't. So we understand what happened, 3 men on a golf course with the individual who is at 3,000. But then another individual says in a golf course, well, my score is 75. And another individual says, well, my score is 220. So is 220 worse than 75? On first pass, you'd probably say yes, because the more calcium you have in your coronary arteries, probably the worse it is for you. And we do know that there are certain brackets of the calcium score that we typically use to understand if a patient is more likely to have a coronary or cardiovascular disease event. And usually the patients who are between 100 and 399 up to 400, they're in this intermediate bracket, right? So if this patient is, let's say, from 1 to 100, he is 75, and another patient is 220, he is, over that threshold, so one patient most likely is a little bit safer than the other. But what do those numbers actually mean, right? Is your intuition correct? And how would you put the numbers in perspective to give you an understanding of not just the amount of atherosclerosis that the coronary arteries may have, let's say in your case, or in the case of those 3 men on a golf course, but also what would be the rates of progression? What is the rate of aging of your arteries? Because this is what calcium score often tells us. And unfortunately, this information does not get passed on to a patient. And if it does get passed into a patient, it's sort of in the kind of the type of things that, is very difficult for a patient to understand. When you tell a patient your calcium score in the 90th percentile, meaning that you're sort of like in the top 10 of people of your age group, ethnicity, and gender, people do understand that, but it's not an easy number to comprehend because it's not very personalized. So let's actually go and understand what these scores do. So for that particular part, I'm going to give you a little demonstration. And so we go back to Multi-Ethnic Study of Atherosclerosis, right? And again, I will put a link for you in the show notes. And again, if you are currently on the audio platform, this is where YouTube will be a little bit better. So what is this multi-ethnic study of atherosclerosis? It's abbreviated as MESA. MESA was actually a fairly large study, and some parts of it are still ongoing, that evaluated individuals without known history of heart disease for the occurrence of cardiovascular events. And the typical cardiovascular events that we'll look at are a heart attack, right? So myocardial infarction. We'll look at stroke. And of course, we'll look at cardiac death or deaths from cardiovascular disease. And so the interesting part of the MESA study is that there was a proportion of individuals in the MESA study that actually got coronary artery calcium scores. And so the investigators then said, okay, if we want to get an estimate, a population estimate, what is likely to happen with an individual in the next 10 years, and in cardiology, 10 years is considered short-term risk because we know that cardiovascular disease and atherosclerosis in general is a lifelong process. So most adults have fairly high lifetime risk of cardiovascular disease or atherosclerosis in any vascular bed, but the short-term risk, 10-year risk, is actually different from person to person. So the investigators here have said, okay, let's try to estimate this short-term risk of a heart attack, risk of a cardiac arrest, a situation where a person has angina because of the blockages in their arteries, they require their stent or bypass surgery, we call it revascularization, as well as the risk of coronary heart disease deaths. Let's combine what we know from the traditional risk factors. And there are quite a few of those risk factors, right? Hypertension, high cholesterol, diabetes, family history. Let's bring it together with the coronary artery calcium score. And when we provide that score, let's try to calculate it in a way that a person could understand by correlating it into the coronary age. So what is the coronary age? It's simply an age at which an individual, average healthy individual, has the same calcium score that a person of interest has. So for example, as we get older, it is unfortunately the sign of aging is that most of us will not have a calcium score of 0, right? We will have some amount of atherosclerosis in our coronary arteries, some people more than others. And we know based on age and gender where most people roughly should be based on those numbers. In other words, just as you perhaps expect that your hair may turn grayer when you're in your 50s, you may also expect that there will be a certain amount of coronary calcium in your coronary arteries. But here, the coronary age allows us to take your numbers and actually use these numbers to give you an idea how fast your arteries are aging, right? So that arterial age, coronary artery age, vascular age comes into consideration. And the reason that I want to do this with you is that I want you to understand the implication of the coronary artery calcium, that single number gives you more than just an estimated risk of having cardiac events over time. And for most people, even in the higher brackets of the coronary artery calcium score, while the risk is high, it's not, in a place where you need to rush and have a procedure. That's actually a minority of the individuals. So we'll run right now through this exercise. We'll do it twice. And I already queued in some of the information here. So let's deal first with a man on a golf course who says that his calcium score is 220. And for the purposes of this demonstration, I made him 56 years old. I picked his ethnicity as Caucasian because just to equalize things and sort of have them all of the same race or ethnicity, but obviously that could shift depending on a person's population. And in the MESA calculator, one could actually specify these were the groups that were studied: Caucasian, Chinese, African Americans, and Hispanic patients. So this happens to be a Caucasian patient. And so this patient is not a diabetic. He doesn't smoke. He doesn't have a family history of a heart attack. And his cholesterol numbers are sort of the type of numbers that are very commonly seen in clinical practice. They're not too high and they're not too low. They're certainly not optimal, but his total cholesterol is 220. And I'm sure a lot of you are walking around with total cholesterol between 200 and 220. The HDL cholesterol is 45. The systolic blood pressure is 120, which again is pretty good. Let's assume that he is not hypertensive, not on any hypertensive medications, not on any lipid-lowering medications. So what does the coronary calculator tells us? Well, if we ignore his calcium score, the coronary calculator will tell us, not bad. His 10-year risk of coronary heart disease events isn't intermediate or high. It's actually quite low, and we typically cut off at 7.5%. And he may be just a touch younger based on all these numbers without accounting for coronary calcium. So good news for him. However, if we bring in the coronary calcium, this is what we see. The coronary calcium of 220 in a 56-year-old male, just given him a coronary artery age of 69. Now, this is 13 years older than his chronological age. In addition, it nearly doubled his risk of coronary heart disease events, putting him in the intermediate risk group. This is where the management shifts, right? Because what we have now is accelerated atherosclerosis. And the coronary artery calcium score of 220 in a 56-year-old man is actually telling us that his heart arteries are the ones of a 69-year-old guy. So he's way ahead of his peers, of the average in his group based on age, gender, and ethnicity in terms of the process of coronary atherosclerosis. Now, this, of course, is very concerning. So let us flip into the arterial age calculator. And why do I use both of these calculators? I use both of these calculators because you already know, probably from your own research or just listening to some of my podcasts, is that aging process does not affect every organ in the same way. There are some organs that age quicker and some organs that age just at the expected pace, and some organs that age slower. Well, the same is true in the arterial tree. The arterial tree is very vast. So certain places in the arterial tree may be aging a little bit faster, and other places may be aging a little bit slower, and others are just on time. So the investigators actually used the MESA study and the coronary artery calcium score to derive a more global variable called arterial age.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing. However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping.
So let's go and plug in our numbers. So we said that this man on the golf course, the score is 220. He is 56 years old, obviously a male patient. I gave him a cholesterol of 220, which isn't even all that high. His HDL cholesterol is 45. His blood pressure is 120. He does not smoke and he does not use any medications. And we're going to go ahead and calculate his arterial age. So what are we seeing here? We're seeing that his estimated arterial age based on this coronary artery calcium 220 is 78, right? So remember that coronary artery age computed him at 69. This is 78. So, on average, he is sort of, while he is 56, he is more like 70-year-old in terms of the atherosclerotic process. And so you could see here that the risk of heart events, now this is really important because there is a distinction in cardiology between hard cardiac events, and hard events are what we mentioned, a MI, stroke, cardiac death. You could see here that based on his chronological age only at 56, there is a 10% risk of him having a heart-related event. But if instead we flip the switch and say arterial age calculation, his risk is actually 30%. So it triples, right? So this is what I find very important to impart on the adults and on the patients. And, I discuss it with my patients when I see them, is that this is now an opportunity for a patient to make a decision with how aggressively or comprehensively they wish to be treated. Because while there could be 56 based on their chronological age, their birth certificate or driver license, they actually have the arteries of a 70-some-year-old, right? So, but remember that there were 3 men on the golf course. So let's say that another man on the golf course is not 56, he's 66. We're going to give him exactly the same numbers. Nothing else will switch here. And we're going to go back to the previous calculator so that you could see. Now, a 66-year-old certainly is in a different boat, because remember how I said that a 66-year-old, we do know from the studies that as people get older, the amount of coronary artery calcium increases. Now, you could see, though, that he's still not in the best place because, again, his age, for a 66-year-old, he is in his 70s, so sort of 78 in terms of the arterial age. And his risk estimate using just on age alone is 12% for cardiovascular disease events, and it almost double, not triple, but double when we plugged in the arterial age calculation. Now we can go back to the coronary age calculator here that we used previously, and we now can run it for a 66-year-old person. Again, this is what you had seen with the 56-year-old man. Now it's a 66-year-old man. We're going to set all of the parameters here exactly the same. So the only variable is actually age, right? These patients are not different in terms of their total cholesterol, their HDL cholesterol, their blood pressure, family history, whether they're taking medications or not. And you could see here that if we didn't have a calcium score, we would say, not bad. He's sort of approaching this intermediate range, and his coronary age is actually somewhat younger. If we didn't have a calcium score just based on the blood pressure and the lipid numbers, which are very powerful risk factors. But when we put the calcium score into the equation, you could see that he goes into that intermediate risk range. His risk increases close to 40% or so, and his coronary age is 72. Remember, his arterial age was 78. So again, as compared with his peers, with other 66-year-old men, he is ahead of the pack, right? And that is not obviously where we want our patients to be. If anything, we want him to be doing better than the average, right? Now, let's see what happens on the other hand, and we're going to stick with the 66-year-old, and then we're going to switch into the 75, right? So you're beginning to see right now that the age is a very powerful factor, because the number 220, while it's sort of in the middle and not as terrible as 3,000, actually means different level of atherosclerosis acceleration for a person, certainly based on their age group. But of course, there are other factors, and we kept those other factors the same. We kept blood pressure the same. We kept cholesterol the same. We kept family history the same. These men were not on medication. So we kept everything the same except for age. And you had seen how impactful translating the coronary calcium scores into the coronary age and arterial age actually is, because it's giving you and me, or you and your doctor, an opportunity not just to deal with the absolute number, but to unravel the root causes that are pushing you into this accelerated atherosclerosis, right? And accelerated atherosclerosis is essentially aging of the arteries. Are your arteries aging faster than you? And for many patients, this actually is the case. But let's do something differently. Let's now say, remember, there was additional person on that golf course, and they said that their coronary artery calcium was 75. And so I'm going to do a 56-year-old first, and you could see it here. So let's say it's a 56-year-old man, not a 66-year-old man, and the coronary artery calcium is 75, and I kept everything else the same. So we're going to go and calculate this, and you could see that without the coronary calcium, this man would have been in pretty good shape, actually not, a whole lot different when you don't incorporate coronary calcium, because it's the same calculation. But when we do incorporate coronary artery calcium, you could see that he's sort of approaching this intermediate risk group, and he is aging a bit faster than his peers, but certainly not as dramatically when the coronary artery calcium was 220. So lower is better, especially if you're older, because if we're going to go ahead and put in a 66-year-old man instead, whose coronary artery calcium is 75, and calculate it, you could see that this is actually what's expected, right? So this is a situation where this calcium score of 75 in a 66-year-old man, based on all the combination of different risk factors, certainly puts him in the intermediate risk group, but that's the expectation based on age and what we know about coronary artery calcium scores. One of the interesting things here is that, as a person may be on par with their peers or accelerated versus their peers, there are definitely people who are actually doing better than the peer group. So let's just, for the sake of demonstration, we're going to go and we're going to set this calcium score to 10, right? Really, really low number. You could set it to 0 if you want. It doesn't really matter. And you could see here that this individual, while they do have coronary artery calcium score, are actually doing really well, right? They are performing better than the reference group or the peer group, and their atherosclerotic process is actually slower than what we would expect, right? Because here they end up with a coronary age of 54. which means they must have done something right for themselves, right? They have achieved, lifestyle modification through diet and exercise and perhaps supplementation or medications, whatever it is that they're doing. They have actually achieved a slowing of atherosclerosis. And I want to take this time here with this demonstration to kind of address the language that we use when it comes to coronary artery plaques and when it comes to coronary artery calcium scores, for example. So a lot of the times patients come in and they say, Doc, I want to reverse my plaques. And what I found out by asking them through sort of, just being curious is that many patients think of the reversal as a complete restoration of normal blood vessels lining, right? They think that reversal means that somehow all the things that happen in the blood vessel wall, all the inflammation and remodeling and plaque growth and maybe, plaque rupture or stabilization, they think that all of these could be sort of unwound and they could be taken back to the state where they were much younger and those arteries didn't really have any buildup in them. Unfortunately, this is biologically not possible. Once a person has plaques in their arteries, whether it's coronary arteries or carotid arteries, we can certainly help them to slow down the progression and cause a regression, meaning an improvement and solidification, fibrosis, or even calcification of these plaques, but we can't completely reverse them. And this is super important because I'd like, for you to understand that there are certainly things that you can do. And maybe let's say that this patient, let's put him back. He's 66-year-old. He is 220 right now, or let's make him 56, right? So because that 56-year-old guy, the situation wasn't as great for him because he was ahead of the curve on the coronary artery age and also on his arterial age. And you could see that if he is 56 and has a fairly decent lipid profile and normal blood pressure, and he doesn't smoke and really doesn't have, family history and not on any medications, he still has the arteries of a 69-year-old. So let's say time goes by and, he decides to, let's say it's 5 years, right? 5 years down the road, he is now 61 and he decides to repeat his calcium score. Now, you will probably find that most of the cardiology literature and cardiology guidelines do not encourage a repeat of the calcium scores. And neither do I, because there is a lot of variability in the calcium score measurements for people whose calcium score isn't zero. If your calcium score is zero, absolutely at 5-year mark, you may wish to repeat it because there is a proportion of patients in some studies up to 20% who will actually progress as they age, of course, and their calcium score becomes greater than zero. And then we have to put it in perspective and understand, what is the age of the coronary arteries? What is the arterial age? Are they now progressing in terms of their cardiac risk? And elevating their cardiac risk. But let's say this gentleman, he's 61, and this is really common in clinical practice. People come and say, oh, doc, I had a calcium score, whatever number of years ago, and now I had repeated it. So let's say that, he's gone to the same place, same machine, and now his coronary artery calcium score 5 years later is 320. So we're going to go here and we're going to say, well, he's gotten older, right? He's 5 years older. So we would expect more coronary artery calcium in this age group. He had somewhat narrowed his gap between his chronological age and his coronary artery age, but Not really by a lot. So you could see that it hadn't really changed anything, right? Now let's come back to a situation so that you get kind of a full understanding of this. And one of my goals is to try to flip you away from just looking at the numbers so that you can actually see the big picture using these numbers together. Let's say this 56-year-old calcium score was actually 75, right? Now, we already had looked at that scenario and we said that scenario is better than a calcium score of 220, right? So lower is better. Zero would have been the most optimal case, but it's not the case here. You could see that this individual is sort of on the border. The coronary age is still much more advanced than, I would like to see in my patients, right? He's 56, but has the artery of a 63-year-old, but at least it's not, the 70-some-year-old that it would have been if we had him at a calcium score of 220. But let's say, now what, right? So now an individual has this calcium score of 75. They're 56 years of age. They're not a diabetic. They're not a smoker. So what else could actually give us an estimate of how fast the coronary arteries are aging? And so let's give this individual a family history of a heart attack. Now, a family history of having heart disease is a tough area because a lot of the times parents or grandparents, they lived in a different time frame, right? The expectations of people, the environment that they lived in may have been very different. We know, for example, that in 1950s, 1960s, we didn't have as much processed food. We didn't have as much disruption sort of to our nutrition. We certainly didn't have enough time to pollute our environment as badly as it is polluted now. So, these generations are not exactly comparable. But let's say that, this happens to be a man on a golf course, right? Three men walk into the golf course. And for this particular guy, the calcium score is 75, so he is a bit ahead of the curve from his peers, but he also has a father who had a heart attack at the age that he is now, let's say 56. So let's say if this actually changes our estimate, and you could see that it changed our estimate by quite a bit. So family history is a very important component. Family history very often correlates with some genetic findings, but not always. There are other factors, environmental factors, of course, that are shaping the family history and the influence on the offspring, right? And we call a lot of these environmental influences that are interacting with our genome epigenetics. And you may want to look at my episode on biological aging because that's where we talk about epigenetics all the time, right? So we can actually, in this individual, have a somewhat different approach and perhaps also look at the genetic and epigenetic factors because they have family history. Let's now remove this family history from this equation. And I recently had a patient, and I'm going to put exactly the numbers that the patient provided. So this patient is 56 years old, male patient. The calcium score is 220, which is a fairly recent score. And up until recently, the cholesterol, the blood pressure is fine. His cholesterol numbers were actually very good. His total cholesterol was in 180s or so, and HDL cholesterol was about 45 or so. He was taking lipid lowering medication for it because since his late 20s, he was found to have high lipid levels. And he reported that while no one had a heart attack in the family, there was one of the parents actually had very, very high cholesterol levels. So we're going to go ahead and calculate his 10-year risk. And you could see that even though his total cholesterol levels appear to be quite acceptable, the algorithm is figuring out that being on a lipid lowering medication, he is someone who is now in a high risk group, right? And you could see that he's trending into those 60s and his chronological age is 13 years older than coronary artery age is 13 years older than his chronological age, right? Now, I want you to understand that it's not the medication that's doing it, right? Medication doesn't have the power to influence, aging of the arteries. If anything, some of the medications can help us to offset aging of the arteries. It simply factors into the continuum of risk. So this patient actually decided to stop his medications, not prescribed by me. This is just, an individual who recently had an initial consult with us. And once he stopped his medications, this is what happened. His total cholesterol went to 345. And I believe the HDL cholesterol was something like 87, but let's put it in there, right? So we're going to calculate his risk, right? So you could see here that the risk continues to be high, right? But it's not that much different, a little bit different than when he was on medication. So let's do it again. So when he was on medication, let's actually keep the numbers consistent. He was 186 and his HDL cholesterol was 87. And very often with medications, there's very slight changes in HDL cholesterol. Let's sort of give it a round number. Let's make it 90 here. We're going to say that yes, he's on lipid lowering medication. Let's calculate his 10-year risk. And you could see here that his 10-year risk is, this is a real patient number now, while he's on medication with a calcium score of 220, because his total cholesterol is in a reasonable range and his HDL cholesterol is in a reasonable range, actually very good and potentially genetically driven to be a little bit high. He is somewhat ahead of the curve. He's being treated. Right now, let's see what happens if he is actually now stops the medication. And this is what we saw. The total cholesterol shoot up to 345 and the HDL cholesterol stayed roughly the same. You could see here that what that tells us is that the coronary artery age is now 70, right? So where is the truth? What is this person to do? How are they to make a decision? Because remember that this coronary age, it's very useful, but it's still a reference to a population of patients, right? What this calculator telling us is that taking all together the age, the gender, ethnicity, blood pressure numbers, family history, smoking or not, medication or not, as well as some basic cholesterol numbers, we could end up in different areas. So can we truly know what this person's vascular age is? Because right now we're simply provided with an estimate, right? And the estimate is that taking as a composite this gentleman on a golf course, 56-year-old with a score of 220, if the numbers are exactly as you see them on the screen and he is not taking medications, that actually means that his coronary age is 70. So this is interesting because for many, many years, this patient was treated with medication. And you had seen that on medication, he had actually a very good lipid profile, right? I'm going to put it in here again. 186 he was, and we said he's on lipid lowering medication, and we're going to go ahead and calculate this risk, right? And you could see that while he was being treated with medication mitigated some of the predispositions that he had, right? But what really is his vascular age? Because what I'm showing you right now is a reference estimate, right? We have gone through the exercise where we're simply taking this person, their gender, their age, their ethnicity, plugging in all the numbers and saying, well, this is what those numbers mean right now, right? What actually is his vascular age? And is there a way for us to understand the vascular age for this person, not as a reference toward kind of a broader population, but in a way that not only references them to a population of patients, but also allows us to monitor if there is a progression of atherosclerosis or regression, right? And you now know that when people say reversal, very often they imply regression and the healing of these atherosclerotic plaques, whatever they are. So there actually is a test like this that we can use. It's a very easy test to have. It could be used quite commonly, and actually most of you probably could ask your doctor to derive this parameter if you had a specific ultrasound, and if not, it's fairly easy to get. We certainly provide it for our patients, and this specific test is called Carotid Intima Media Thickness. So I am going to do my next episode on carotid intima media thickness, because it's another concept. It's fairly involved, and I don't want to confuse you right now. I just want you to understand that there is more than one way to understand the arterial age. And the arterial age is a powerful variable because it allows us to gauge where the person actually is and how fast they're moving along this tunnel, if you will, of atherosclerotic changes. So February is coming up, actually in a couple of days, and February is American Heart Health Month. And during the American Heart Health Month, if you join us as a guest in the Holistic Heart University, you will actually get 2 weeks of free access to certain places that are usually part of our memberships. And I want you to consider attending a presentation that we have already queued up in the Holistic Heart University called You're Only as Old as Your Arteries, because I will actually demonstrate the carotid artery technique so that you will see how one gets it and what gets measured and why you may want to get that measured. Also, for those patients who are seeing us in the New York, New Jersey, Connecticut area, or are willing to travel to New York City or Long Island, we now provide full vascular scans that include CIMT and a lot of other vascular determinations, including the echocardiogram, which is the ultrasound of your heart, and the scanning of the abdominal aorta, another place where atherosclerotic plaques may actually be hiding. So join us in February at the Holistic Heart University, attend some of the presentations, reach out if you want to have a specific coronary and arterial age assessment. It's easy enough to get. You could see that these formulas are in the public domain, and I'm happy to walk you through your specific numbers and give you an understanding what the next actionable steps are. Or if you're local or willing to travel, come in so that we can actually do the appropriate vascular scanning and give you an understanding where you are at the moment, right? Because this is what personalized medicine is all about. And I am hopeful that you will take advantage of some of these resources, which are entirely free. Certainly MESA calculator is free. And the 2 weeks in February, any 2 weeks of your choice, you'll get free access to a lot of Holistic Heart University events that I think you may like, and a lot of resources to really help you up-level your heart health. And with that, until we discuss the next step in the vascular age measurement, which will be carotid intima media thickness.
Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Heart Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.